Yes.
Oh, thank goodness. So I like things informal. So if people have questions or something's not clear, please let me know. And Jesse, if you don't mind manning the chat, I can only do one thing at one time, and I can't give a talk and read the chat at the same time.
Absolutely.
I really appreciate it. My kids can, but I'm not of that generation. I'm going to provide a bit of background and then go through the developmental history of CAR T with a particular relevance to what we have or don't have in Canada. So I'll begin by, let me go to slideshow, that might help. Talking about immunotherapy in general, because we are really in a new era of myeloma. And we have several platforms, if you will, of immunotherapy, and they all share certain features that I will talk about briefly. One is you need to identify something on the surface of a myeloma or other cancer cell to be a target for different immune activities. And you want that target limited to the cell that needs to be destroyed, or otherwise you'll have collateral damage. The normal cells can be attacked by the immune mechanism. And then you need some sort of immune way to kill the cells, either in practical terms, an antibody, or by cells that recognize these markers and kill the myeloma cell by a variety of mechanisms. So we classify immune therapy by antibodies that attack the myeloma cells or immune cells. And naked antibodies, if you will, refer to what we have on the market, daratumumab and isatuximab. They bind to CD38 on the myeloma cells, and they call in different armies of immune cells to kill the myeloma cell. And this really was a landmark development for myeloma. There's antibody drug conjugates, and I'll demonstrate this a bit in a minute. That's when the antibody here has a poison on it that can then be delivered to the myeloma cell. Then we have these so-called bispecific antibodies, or BiTEs, or duo bodies. And then, of course, for immune cells, being the what we call effector, or the active immune cell that kills the myeloma, we can have T cells. T lymphocytes are now their CARs made with another cell that's kind of like a lymphoid cell called a natural killer cell. And these have the advantage of potentially no cytokine release syndrome, because they kill tumor cells a different way. Now, what are the different targets on a myeloma cell? And of course, each cancer cell, a different type of cancer, has a different almost landscape on its surface. And I don't have the best analogy. I thought maybe this is like a fingerprint, but it's more like geography. You have your mesa here, your mountain range here, your low-lying forest here, and you want your immune treatment to be able to attach to that. Now, this is what we have for daratumumab and isatuximab, but the three main targets that are limited to the surface of myeloma cells with not much expression on normal cells are BCMA, which is important in development of plasma cells, and then GPRC5D and FHRH5. These are the main ones that have found their way into clinical development in myeloma. So again, these three types of immune therapy, we have the most experience in Canada with the antibody drug conjugate. This is belamaf or belantamab, and it has a toxin that is then delivered to the myeloma cells, which can enhance the killing beyond what the immune effector processes can do. The problem is this warhead damages the cornea. And we've all heard about the eye toxicity with belamaf. On the other hand, it is not permanent. It always recedes. It is annoying. And belamaf, for all its warts, has, when you look at the data in our trials, has really helped many people with myeloma in Canada until we can get other drugs into our armamentarium. Now, the bites, this is sort of a funny looking bite, but usually both this site and this site bind to the same target on a myeloma cell, but the bispecifics are unique in that the tumor binds on one side, but the other side attaches to a T cell, and it brings the killer cell right beside the tumor cell, so a war develops. And then, of course, what is almost the ultimate in sophistication is you actually take something like an antibody, you can call it a receptor here, stick it into the T cell, killer T cell directly, so the tumor binds here, and the T cell is right there, and you can enhance its function so it kills more effectively. And this is what we're going to be talking about today. Why do I talk about even the bispecifics? There has been a lot of discussion is which one's going to be the winner for patient care. And there are pros and cons of each of these. I think most of us think there'll be a role for each of these, but they share a certain similarity in how they work to kill cells. I probably shouldn't spend as much time on bispecifics, but we expect one to be approved by Health Canada very soon, teclistamab. And I've already talked about how it works, but it releases these granules, these different little cytokines, markers that can kill the tumor cells. So you do see cytokine release syndrome, and you do see neurologic side effects, just like you do with CAR T. They're generally milder. The real advantages is these are off the shelf. There's no time for processing them. They can be given under the skin intermittently. They can be stopped and restarted, and certainly are worthy of further development. But here we are with our main focus of today's presentation, and that's CAR T cell therapy. So there are similarities and certainly differences with autologous stem cell transplantation. Both procedures start out with leukapheresis, but instead of collecting stem cells to plant a new healthy bone marrow, all the cell lines in the bone marrow, the dials on the machine are set differently, so you collect T cells, T lymphocytes that are a subset of all your white cells in the bloodstream, which also include, of course, neutrophils. These are shipped to a lab, and a antibody-like molecule is stuck on it, if you will, that will recognize one of those surface markers like was shown previously, BCMA or one of the other targets. Then this population is expanded, it's grown. You take out the processing material, and then you have your CAR T cells. Chemotherapy is given. Now, in a stem cell transplant, it's given to really kill down the myeloma population. And the stem cells are the rescue, so the blood counts come back as quickly as they can. Here, the chemotherapy is not the most effective for myeloma. It helps a little bit, but its purpose is to actually immunosuppress someone so that these cells have an advantage and can develop into a high number in the circulation. So they are then reinfused into the patient after what we call lymphodepleting treatment to get rid of the other lymphocytes and cells. It does make all the blood counts go down like all chemotherapy. Now, this type of approach was first done in childhood acute lymphoblastic leukemia, ALL, and non-Hodgkin's lymphoma. And a different marker on these lymphoid populations were used, CD19. And I show this because in individuals with really a terrible prognosis, these treatments are felt to be curative. And there are 3 of these CARs that are on the market in Canada. And that puts us at a bit of a disadvantage in myeloma, because these are diseases that have curative potential without CAR T. So they have a very different biology than myeloma, which is really a very stubborn disease. It can be controlled, but it really loves to come back. And I think when our funders and our regulators look at these curves, it does put our group at a little bit of a disadvantage, that at least so far the curative potential has not been convincing, although there are many strategies underway to try to make CAR T in myeloma curative. So this is a closer look at the receptor stuck on the T cell, and you can see that this is the kind of antibody-like. This can be directed against, most commonly, BCMA on the tumor cell. And then you have these other domains that enhance the effect or anchor this on the T cell. So the race is on among different pharma to develop variations, and this is just a cartoon to show what these component differences might be. And unfortunately, already 2 of these have dropped out of the race, even though there were abstracts at meetings that suggested they were effective. They're not being developed further, and I don't think we'll ever know quite why. But it does reflect the intense competition among pharma to develop these. Each of these products is priced, I think Cilta-cel is going to be $461,000 as a drug. One of the challenges is that it's not just a drug, it's all the lymphodepleting chemo, the hospitalization, the antibiotics, the GCSF, the intense supportive care that accompanies this, which does not accompany a usual cancer drug that's given in the clinic. There's no ancillary funding that needs to go except to pay the nurses, cover the cost of the nurses hanging the treatment or injecting it in the pharmacy to mix it up. Here, there's ancillary fees that are about as much as the drug product. So in the US, this is about $1 million procedure per individual. Now, the history of myeloma CAR T development starts with, like all cancer treatments these days, in very advanced disease. And the first studies were not randomized. They didn't have a comparator. So the question is, what's the expectation without CAR T? So this is a US study. It's commonly referenced. It's called the Mammoth study. And what they did is look at people who were refractory to daratumumab or isatuximab, and saw how they did in terms of survival. And this is triple class refractory. This nomenclature is used quite frequently now. These are people whose myeloma has grown through a proteasome inhibitor like bortezomib or carfilzomib, an IMiD, usually lenalidomide and or pomalidomide, and one of these antibodies. So this triple refractory population, this gray line, is often a reference point, and we know that when these drugs have been used up, the response rate's low, and the median progression-free survival, that's the time half of people are in remission longer, half of people have fallen out of remission by that time, is between 3 and 4 months. And the median survival, I didn't deliberately leave this off, but it's I believe in this analysis, it was 9 to 10 months. So this is not a favorable situation for a person with myeloma to face. So, but this was the group that the two main CAR T platforms were assessed in. The Celgene and then BMS, when they bought them over, product is called ide-cel. It has a much longer name I can't say. And the Janssen product, cilta-cel. And these are the KarMMa trials for the ide-cel product and CARTITUDE trials for the cilta-cel. And of course, the usual drug development pathway is to study a treatment in very advanced disease. If it works there and the kinks are worked out, if you will, on the preferable dose and way to give it, then it will be moved up earlier in the disease course. So really, the trial that established proof of principle that this treatment could work, I think probably everyone here recognizes the KarMMa trial. This looked at the situation of myeloma when people had had at least 3 prior regimens, exposed, triple class exposed, and growing through their last treatment, refractory to the last treatment. And actually over half had grown through 5 different treatments, and the median number of prior lines was 6. Almost 40% had disease outside the bone marrow, which we know is hard to control, and 35% had high-risk cytogenetics. It takes about 5 weeks to process, to make the ide-cel CAR T-cell product. So again, when you take people that nothing works and you give them bridging, which the majority received, it doesn't work most of the time, which flags one of the first issues is it takes too long, you know, when you're treating this high need population. So I won't go through all the characteristics. Again, I think this number of median drugs is important. These individuals had high tumor burden, and I think I've discussed these points. Now, what was remarkable is these represent the different dose levels, and it's what they could get from the patient. And they allowed any of these 3 dose levels, but obviously the target preferred collected number of T cells and processed T cells were these numbers here. But you could see the response rate overall was 73%. The blue is the complete remission, or if your free light chains were normal, stringent CR, and your marrow was really free of myeloma, that was stringent CR. And of those that were in CR, they a quarter were MRD negative, which is a more sensitive way to measure the myeloma burden. As all of these products, the responses are seen within the first 4 weeks. The median time to complete response is just under 3 months. And 2 years ago, almost 2 years ago, Health Canada approved this drug, or this agent, for people who'd had at least 3 lines of treatment, including those 3 classes, and were refractory to their last treatment. But as everyone here is well aware, when it went through CADTH without a randomized trial, the main pushback was what is often done with these trials without a comparator built in, i.e. a phase 3 trial or randomized trial. The claim was there's too much uncertainty about how people would have done anyway. And then, of course, even though and then, of course, if the benefit, as shown here, turned out to be for all patients treated, the progression-free survival was about 8.5 months. When you calculate the cost benefit, it was not funded. Even though the overall survival was about 2 years. So the most common side effects, and this is largely from the lymphodepleting treatment, as well as the immune war that takes place, low blood counts, and these can persist quite a while. And of course, we need to be very mindful of certain infections in this phase. Other toxicities are unique to this type of treatment. Cytokine release syndrome is very frequent. It's low grade in most. In ide-cel, it occurs early, lasts about a week, and about 2/3 require what I would call the antidote. Tocilizumab is a rheumatoid arthritis drug that neutralizes one of the cytokines that's released in the T cell killing of the myeloma cells, and that usually settles the process. To me, one of the most worrisome features that we really want to get a handle on and minimize is neurologic toxicity. Now, fortunately, it is severe in only about 6%. It occurs a little later. The mainstay of treatment is steroids, and I'll talk about it a bit more in a minute. Now, close on the heels of the KarMMa trials is the CARTITUDE-1 trial, and its design is very similar, and this diagram just looks a little different. So collect the T cells, give bridging if you can, use 2 drugs in particularly cyclophosphamide in moderately high levels, give the cilta-cel infusion, and then follow up. And I'll have a slide that puts these 2 side by side for reference. Yes, we're not supposed to do that, but it does give us a snapshot of how these treatments compare. And you can see that, again, patients had a median of 6 lines of treatment, 25% at high risk, outside of the bone marrow plasmacytomas, and 13%. And you can see the refractory population here. So again, very heavily pretreated. Now, what made everyone sit up and take note is the response rates were really high, and stringent complete remission was almost 83%. Again, very quick responses, and the duration of response had not yet been reached at this time. And just last month, Health Canada approved cilta-cel, the same indication of as ide-cel, and we're waiting to see what the funding recommendations will be. So if you look at the progression-free survival curves, at 2 years, there are still, the median has not been reached. And if you look at those in stringent CR, at 2 years, 64% are still in remission. And the overall survival at 2 years is just over 70%. So I think, you know, I at the recent ASH meetings, one of the big US speakers was asked, are ide-cel and CARTITUDE about the same? And the answer they gave was yes. But I don't think that question has been settled, and there'll never be a head-to-head trial. Again, just to run through the toxicities, they're very, very similar. CRS is common, fortunately not much grade 3 or greater. It occurs a little later. There's slightly more neurotoxicity, but with every good treatment, there are potentially special considerations or worrisome factors. And what was seen with Cartitude is a more unusual neurotoxicity that was a bit different, and it's been described as a Parkinson's-like entity. I've seen it with lymphoma, which has higher rates of neurotoxicity and CRS. It's curative, but there's more toxicity, and there can be tremor, but there is loss of motion, sort of freezing or stiffness, like can be seen in Parkinson's. So here's the comparison of the two for your reference. Again, there should be warnings here. You can't do cross-trial comparisons. But if you look, we always worry that if results in one group are better than another, maybe it's because one group of patients didn't have high risk or bad features. Maybe they'd only had one line of treatment, and that's why the results are different. It's little to do with the drug or agent itself. But when you look here, they're really quite similar in the characteristics, and an apparent benefit or a better outcome with Cartitude. So where are the pharma companies going from here? It really is a race, and hopefully that race will benefit our patients with this disease. This just lists a bunch of trials, and the next one to be done after approval of ide-cel was to actually do the phase 3 trial, compare it with standard of care in individuals who had progressed through all 3 lines of treatment. So the trial design is shown here. This had 2 to 4 prior regimens, so not 6, and people had to have all 3 classes and refractory to the last regimen. And I think everything else is the same. And what was seen, the standard care arm could get a variety of treatments, basically what they hadn't had before. And somewhat here, they could have had Dara-Pom-dex, Dara-Velcade-dex, Ixazomib RD, Carfilzomib dex, or Elotuzumab. So standard regimens that they were felt not to be refractory to. So what did they find? Overall response rate 70%, and it was considerably better than the standard option. There was more MRD negativity and a longer remission duration. And the progression-free survival was 3 times longer. What I think is a bit striking is this is not that much better than in the very advanced disease, and it is meaningful. But again, is this the home run we've been waiting for? I mean, there's no question that for an individual facing a worrisome or risky relapse, for lack of a better term, that a year is a good thing. But the bites give a year, oftentimes, or even the cell mods in certain combinations can give a year. So is this, I mean, it's proof of principle, but is it the home run we need? So the research goes on. And of course, One way to improve the results of any treatment is to give it before the disease is highly resistant. So the next set of trials with these two products gave ide-cel and cilta-cel earlier in the disease. Now, these are small cohorts, and I'll run through these trials. I basically taken 2 slides for the results of each of these settings and put it into one table because I was putting myself to sleep droning on through all these presentations. So I'll go through this. I'll go through the trials and then I'll summarize the results. It's sort of a snapshot overview. So what the KarMMa platform studied is cohort 2A and 2C. These were individuals who had early relapse. Their myeloma had come back within a year and a half of starting induction, then a transplant, then lenalidomide maintenance. Now, this approach gives over 5 years median progression-free survival, usually. And those individuals who have recurrence earlier are considered obviously a group with more resistant disease, but they've not had a CD38 antibody at least yet, as that's not always part of induction, certainly not in Canada and many jurisdictions. The next cohort were newly diagnosed patients who'd received at least 3 cycles of a PI and IMiD, and they had not had a CD38 antibody, but they had less than a VGPR to stem cell transplant. So these are really potentially kind of one line of prior therapy, but a group that is deserving of better strategies. Now, the CARTITUDE trials took a little bit different. They looked at myeloma 1 to 3 prior lines and were progressing at some point on lenalidomide. Their cohort B was a bit like the early relapse group for ide-cel. These were people who'd had a PI and IMiD, like RVD, induction, and then relapsed within a year of a transplant, not 18 months. And they included non-transplant patients who had RVD and progressed within a year. And then they included individuals who had progressed after a bite or belamaf. So I apologize for the busy slide, but I'll just point your attention to the early relapse 2A and CARTITUDE B. Now, only triple refractory were only 16%. And none of these had CD38 antibodies. And yes, the response rates were high, but the median PFS, again, here is less than 2 years. Oh, sorry, I can't even see with the pictures. Let me see if I can close that. Sorry, I was looking at the median follow-up. Here, the early relapse with no CD38 exposure, even though the response rate was high, it wasn't durable. Again, it was just under a year benefit, whereas CARTITUDE, 90% were free of progression at 1 year, which again makes one stand up and pay attention, I think. The results may be a little bit more encouraging for ide-cel if there was less than a VGPR with transplant. Now, there are patients who have a transplant that aren't in VGPR that go years anyway. They have a different biology. We all see these individuals. So the majority were still progression-free at 2 years. But we really need to watch this group longer. And 1 to 3 prior lines, at a short follow-up, 70% still free of disease. And the last group is really an extremely heavily pretreated group, triple class refractory 90%, and all had another non-CAR T anti-BCMA, and still the response rates were respectable. And we only have response rate for this. So I think these were small trials. They were pilots, and we'll see where they go from here. But already the trials that have been ongoing in Canada, or this one's about to start, are in newly diagnosed patients who have not had their disease progress at all. And you can see where the field is going is that if we've learned how to give these drugs with relative freedom from serious side effects, let's use it at diagnosis. And I think this is where pharma is going. So a couple of, I think 3 centers, including our own, have had CARTITUDE-5. This is a randomized trial, newly diagnosed patients, transplant ineligible. Now, the definition of transplant ineligible is different in the US than in Canada, but this could certainly include, you know, potentially people over 65 that we would ordinarily transplant, but it's a moving target definition. So patients had bortezomib, lenalidomide dex, or Velcade, Revlimid dex, and after several cycles went to cilta-cel versus what we would ordinarily give and are funded for, which is VRD, and then after so many cycles of Velcade, drop it and continue on RD. So we don't know the results of this. We did put several people on this at Princess Margaret. We're eagerly awaiting, but you know, VRD with RD in newly diagnosed transplant eligible patients is going to give, you know, a median of several years. So this will not read out for a while. The CARTITUDE-6 is being done in several centers. CMRG was contacted by the European Myeloma Network that is running the trial, and we're facilitating it. But this is a win-win, whether our patients are randomized to the control arm or the test arm, because everyone receives DARA RVD, and then either goes to cilta-cel or a stem cell transplant. And this is, as most of you are probably aware, is a highly effective induction that we get a CD38 antibody in right at diagnosis. It's going to be a long time before that's funded in Canada. So this is a win-win trial for anyone. They get excellent induction. And I think this is a real test because we expect the control arm to benefit for years. And we'll see, you know, if this is going to be curative, this may be the setting we'll see it. So this is all very well and good, but when I have seen my patients, the real concern is, what do we do with this emerging wave of people who have been through the three major classes, we have many trials for bispecific antibodies. They come and go, and they're being combined with a variety of older agents. We may have teclistamab approved later in the year. But what do we do for our individuals with advanced disease right now? Those trials are finished, except for one, and that's the LUMMICAR study that is now being done as LUMMICAR 2 in Canada and other jurisdictions. But the basis is this platform that we call CT053. This is the company is Carsgen, and the first trials were done in China, which is interesting. That's where Cartitude Cilta-cel came from, and the Chinese study, again, it's the same type of design, people who've had at least 3 lines of treatment, but in China, not everyone gets a CD38 antibody, and it was 22% that were triple refractory. It takes 3 weeks instead of 5 weeks in this trial, and so this was 100 patients, and a median of 4 lines of treatment, high risk cytogenetics in just under half, and 90% were refractory to a PI and IMiD, but the response rate was very high. The stringent complete response was almost half, but what was nice is there were no new toxicities. A grade 3 CRS was 6.9%, no severe ICANS. There was loss of 1 individual to side effects. And the PFS looked very good. Again, short follow-up, but almost 85%. So this trial is ongoing at Princess Margaret. We're the only Canadian site, and these trials, there's only going to be just over 100 people in there. I think when I double checked, there are about 13 centers in the US doing it and 1 in Canada. So we don't always have a slot open, and we are assigned a slot and have to fill it very quickly. The eligibility criteria are shown here. There's nothing particularly striking from others, except people have to also have had a CD38 antibody progressing on the last line of treatment. This is very similar to the advanced disease setting that Cilta-cel and ide-cel, and there can be no prior BCMA. But this is an exciting platform, and I think the more we can get, the better, to get our people with advanced disease this treatment. If it's going to get a couple of years more. So that's a big challenge. So I'm going to turn very briefly to the unique biologic side effects, cytokine release. I won't talk about the hemophagocytic lymphohistiocytic activation syndrome. It's poorly understood. It's seen in several other situations, but it is a complicated entity that's quite rare. Neurotoxicity, and what's very important in the long term, when the acute side effects have passed, is a weakened immune system for long periods of time, and I am aware that is a challenge in with all myeloma treatments, and even sometimes in the absence of treatment. So cytokine release is due to all those little chemicals that are released in response to both try to kill the tumor cells, but when T cells are activated, you can see some of these, see some of them, we can measure them. And we measure, this is a general C-reactive protein and ferritin go up. These are harder to measure. It's like a flu if it develops, and it's very common, any grade, but what we want to avoid is progressing to low blood pressure, low oxygen, and even fatalities initially. And it is associated with a heavier myeloma load. There's more to kill. There's more fire and inflammation when there are more tumor cells. And I think I've already showed this before. Cilta-cel occurs a little later, but the duration is fairly short. And tocilizumab is very effective in stopping the symptoms, although it may need to be repeated. The main manifestation is fever. This diagram lists every possible scary thing that could happen. And fortunately, with myeloma CAR T, it doesn't. But when this goes bad, it can go bad in a way that is unique. It is more toxic in the lymphoma setting, but I think people do need to be aware that it can be very complicated, prolonged, and highly unpleasant. This just shows the different timing for the markers that go up. And this has been described when it occurs as a cytokine storm. We have rigid criteria that we have to move people to the intensive care unit for monitoring. They may need chemical treatment intravenously, continuously, to keep the blood pressure up until it can be controlled. Toxicity for CRS, I've already mentioned. Tocilizumab is the main drug, if not steroids. Neurotoxicity, steroids is what we base the treatment on. The neurotoxicity is deserving. This is the more frequent kind that I'll describe in a minute.
You got your glasses.
We think a lot of it is that these little chemicals pass the blood-brain barrier and cause inflammation. And I'll show you some of the signs and symptoms. There could be passage of the CAR T itself into the central nervous system, brain, and spinal fluid. Now, these are the classic symptoms that range from a little bit of confusion to seizures, and even being almost comatose. Again, the risk of severe is quite low. It occurs later, and it can last a few days. All centers have rigid scoring for assessing this and picking this up early. This is an example of the scoring system. It's not that complicated. Deterioration in handwriting is one of the earliest signs, can be subtle, and problem naming simple items can pick it up early, and treatment can be initiated. This weirder, if you will, the scene with Cilta-cel was the more Parkinson's-like. In the initial CARTITUDE study that was done after a median of 6 lines of treatment, it was 5% of patients, and it may not respond to anything. And risk factors have been defined, particularly a high tumor burden, high-grade CRS, any neurotoxicity, and a lot of CAR T cells. So the mitigation factors have been taken into account, and is one reason that we're not seeing it as much anymore, because the treatment is being given earlier in the disease course before a massive tumor burden, and has become less of a problem. Just in the last few minutes, I'll talk about the effect on the immune system. Now, this is the effect of lymphoma CAR T. It's directed against earlier B cells, but still they go on to potentially become myeloma cells. When you kill the myeloma cells, the CAR T cells can't tell the myeloma cells from the normal plasma cells. So normal plasma cells make our antibodies. So the normal IgG as well as the tumor IgG plummets and may go from a normal of, let's say, 10 to 12 to 0.3, very, very low levels. And it's different for different patients, but it may last a long time. This is the incidence of low antibody levels. These are not myeloma antibodies. These are the good antibodies, and it's up to 100%. Even 40% at 1 year will have low antibody levels. Now, what's been noted is not everyone with very low antibody levels, normal antibodies, has recurrent infections, but some people do, and we are mindful that people are at risk because antibodies are an important arm of our immune system to fight infection, just like neutrophils and just like other types of cells. So there is a pattern of infections. Early infections are usually bacterial, particularly pneumonia, but there's also a smaller risk of fungal infections that we rarely see with normal or previous myeloma treatments. Viral infections must be considered. Shingles and herpetic infections are important, but also infections that are more often seen in allogeneic transplantation. Someone else donates stem cells, cytomegalovirus and BK virus, which can affect the kidneys. So late infections are mostly due to respiratory virus and sometimes pneumonia. This is more specifically for myeloma, and again, you can see the same type of pattern. Now, when you know your enemy, you can devise a strategy to preempt or manage it. And so we're very diligent about screening for infection ahead of time, preventing infection, jumping on an infection at the first sign, and considering IVIG or subcutaneous IG, normal people's antibodies as replacement, and then, excuse me, repeating vaccinations. So this is our list of diseases we screen for before CAR T. It's not dissimilar from what we do for a stem cell transplant, but we also look for evidence of prior herpes infections, which we know will reactivate, and for people in the tropics. And we have a number of people who's immigrated from the Caribbean. Strongyloides is a parasite that can get us into trouble and may need to be treated. Infection prophylaxis is important. we give everyone a cyclovir for virus. Most centers will give some sort of antibacterial until the neutrophils recover, some sort of antifungal. And pneumocystis is an odd organism, probably parasitic, that can haunt us for many months after treatment, and it's basically completely preventable by 3 Septra tablets per week. And it can be a nasty pneumonia and can be fatal, and should be continued potentially indefinitely. The alternatives are not as effective, and unfortunately, Septra DS is a horse pill that looks like the size of Kansas City. It does come in a pediatric solution, but it is so important. Revaccination, we have an extensive revaccination recommendation to start at least 6 months later to allow some recovery of immune function. No live vaccinations within at least a year. I never give live vaccines to my stem cell transplant or CAR T patients, but these are the recommendations are a little more liberal. I'll just mention that COVID can be a huge problem in CAR T patients, and with a very high mortality rate. So we are very keen to repeat the primary COVID studies series starting 3 months post-transplant. Not everyone will respond, but we want to do due diligence to protect our patients. I know in the past there have been at least one other center in Canada that would not didn't want to do CAR T in someone who wouldn't be vaccinated pre CAR T, and it was a big ethical issue because the fatality is so high. So, summary and conclusions. This is an incredibly exciting new area that fills an unmet need, and I think an unmet need is lack of cure. So I'm all for this being utilized and evaluated as widely as possible, as early as possible. We have many new indications and a number of constructs under evaluation. Some of the newer platforms have been rejigged to enhance memory cells in memory CAR T cells because they may fizzle out and we lose the benefit, and that is felt to be a significant contributor to relapse. We have new targets. There is a product with much more rapid processing time that is under development. We need to understand the toxicities better. We need to be diligent of infection. Unfortunately, cost is a challenge. And the other side of that is we need more infrastructure and staff resources that isn't in existence now to care for the emerging population of CAR T cell transplant candidates. There was a little bit of broadening of this for lymphoma, but to broaden it more, and some provinces are not doing it yet because we have a real staff shortage in healthcare now as a consequence of COVID. So everyone is very short-staffed without the need to accommodate this emerging treatment. However, I think hope is on the horizon, and we will be pushing for access to this modality for our myeloma population. So I'd like to thank everyone for your attention. Special thanks to our constituency, who are patients and caregivers, to Myeloma Canada for their support. the Bloom Chair at Princess Margaret and the Princess Margaret Foundation. So thank you very much.